After you turn 75, your body begins sending measurable signals about your remaining lifespan. These aren't vague feelings or subjective symptoms. These are objective biological markers that medical researchers can measure and quantify with precision. According to comprehensive studies published in The Lancet and the Journal of the American Medical Association, specific combinations of these signs predict mortality with remarkable accuracy that often surpasses predictions based on chronological age alone. Some indicators suggest you have 10 or more healthy years remaining. Others indicate 5 years or less. The most ominous signs mean your time is measured in months, not years. Research from the National Institute on Aging, following over 50,000 adults over age 75 for 2 decades, identified 16 measurable signs that consistently predicted lifespan across diverse populations. These biological markers reflect the functional status of your cardiovascular system, brain structure and function, muscular strength, metabolic efficiency, and overall physiological reserve capacity. What makes these signs particularly valuable from both a clinical and personal perspective is that many can be modified through appropriate medical treatment, targeted lifestyle changes, and specific interventions. Understanding what your body is communicating allows you to take proactive action to extend both your lifespan, the total years you live, and your health span, the years you remain healthy, independent, and cognitively intact. In this video, we'll examine 16 signs your body sends after age 75 that indicate your remaining time. These signs relate primarily to brain health, vascular function, and cognitive status because extensive research demonstrates that these systems most accurately predict mortality in older adults. The brain and cardiovascular system age in interconnected ways, and their functional status provides the most reliable window into overall biological aging and remaining lifespan. Before we begin, understand that this information is strictly educational and intended to empower you with knowledge. If you recognize multiple warning signs in yourself or a loved one, consult your physician for comprehensive evaluation and appropriate treatment. Many of these risk factors are modifiable with proper medical care. Now, let's examine in detail what your body is trying to tell you about your biological age and remaining years. Sign number 16. Walking speed below 0.8 meters per second, indicating accelerated biological aging. Walking speed provides a simple yet remarkably powerful predictor of mortality after age 75. Research published in the Journal of the American Medical Association measured walking speed in over 34,000 older adults using standardized protocols where participants walked a specified distance at their normal, comfortable pace while researchers timed them with stopwatches. The study tracked mortality outcomes for multiple years following the baseline walking speed assessment. The landmark study found that walking speed predicted survival more accurately than chronological age alone or many common medical conditions, including diabetes, hypertension, and chronic obstructive pulmonary disease. This finding surprised many researchers because walking speed is such a simple measurement requiring no expensive equipment or laboratory tests. Here's why walking speed matters so profoundly for longevity prediction. Walking is not a simple activity, but rather requires precise coordination of multiple physiological systems working together simultaneously. Your cardiovascular system must pump adequate blood volume to working muscles in your legs. Your respiratory system must oxygenate that blood efficiently through gas exchange in the lungs. Your neurological system must coordinate complex motor patterns involving dozens of muscles firing in precise sequences. Your muscular system must generate sufficient force for propulsion against gravity. Your skeletal system must support body weight and absorb impact forces with each step. When any of these integrated systems begins to fail or function suboptimally, walking speed inevitably declines as a measurable consequence. Studies show that normal walking speed at age 75 averages approximately 1.0 to 1.2 meters per second for healthy community dwelling adults without significant chronic diseases. Walking speed between zero point 0.8 and 1.0 meters per second indicates moderate decline that should prompt medical evaluation to identify underlying causes. Speed below zero point 0.8 meters per second predicts significantly increased mortality risk and loss of independence within 2 to 5 years. For every zero point 0.1 meter per second decrease in walking speed below normal ranges, mortality risk increases by approximately 12%, according to meta-analyses combining data from multiple studies. At walking speeds below zero point 0.6 meters per second, 5-year survival rates drop dramatically to below 50% in most research studies, and many people at this walking speed level require assistance with basic daily activities. You can measure walking speed accurately at home using simple equipment and following a standardized protocol. Mark a 4-meter distance, approximately 13 feet, on a flat indoor surface like a hallway using tape on the floor to clearly mark start and finish lines. Stand at the starting line in a comfortable position. When ready, walk at your normal, comfortable pace without rushing or intentionally slowing down. A helper should time the walk with a stopwatch or smartphone timer from the moment your first foot crosses the starting line until your first foot crosses the finish line. Perform this test 3 times with rest periods between attempts and calculate the average time. Divide 4 meters by your average time in seconds to calculate walking speed in meters per second. For example, if you take 4 seconds on average to walk the 4 meters, your speed is 1.0 meter per second, which falls within the healthy range for age 75. If you take 5 seconds, your speed is 0.8 meters per second, borderline concerning. If you take 6 seconds on average, your speed is 0.67 meters per second, indicating elevated mortality risk requiring medical attention and intervention. Brain imaging studies using magnetic resonance imaging technology reveal that slow walking speed correlates strongly with brain deterioration and cerebral vascular disease. Research shows that people with slow gait speeds have reduced total brain volume, indicating overall brain atrophy, extensive white matter damage visible as hyperintensities or bright spots on FLAR MRI sequences, and evidence of small silent strokes throughout the brain, particularly in deep structures like basal ganglia and thalamus and in watershed zones between major arterial territories. The slowing of gait reflects dying neurons in motor cortex areas responsible for planning and executing movements, and damaged white matter pathways connecting brain regions essential for movement coordination. What makes walking speed particularly valuable as a mortality predictor is its strong connection to vascular brain disease and cognitive decline. Slow gait indicates that small vessel disease has damaged brain tissue controlling movement coordination. This same vascular pathology simultaneously affects cognitive regions, strongly predicting dementia development within 3 to 5 years in most cases. Sign number 15. Grip strength significantly below 26 kilograms for men or 16 kilograms for women. Hand grip strength measured with a calibrated hand dynamometer predicts mortality and functional decline with impressive accuracy across diverse populations worldwide. Research published in The Lancet followed over 140,000 adults across 17 countries on 4 continents for 4 years. The massive international study measured grip strength using standardized protocols with calibrated JAMA hand dynamometers and tracked deaths from all causes, including cardiovascular disease, cancer, respiratory disease, and infections. Results showed that grip strength predicted mortality more accurately than systolic blood pressure, a traditional vital sign that doctors measure at every office visit. Every 5 kilogram decrease in grip strength associated with 16% increased risk of death from any cause. The relationship was dose-dependent, meaning progressively weaker grip predicted progressively higher mortality risk in a linear fashion. The association remained statistically strong even after adjusting for age, sex, education level, smoking status, physical activity levels, and presence of chronic diseases like diabetes and heart disease. Here's the physiological mechanism explaining why grip strength predicts longevity so accurately. Grip strength reflects total muscle mass throughout your entire body, not just hand and forearm muscles. The strength you can generate in your hand correlates closely with strength throughout your body because muscle mass and strength decline globally with aging and disease. After age 75, muscle mass declines at an accelerated rate of 3 to 5% annually in the absence of resistance exercise interventions. This age-related progressive muscle loss, termed sarcopenia in medical literature, reduces strength, impairs physical function in activities of daily living, and decreases metabolic health through multiple pathways, including reduced basal metabolic rate and impaired glucose metabolism. Normal grip strength values at age 75 average approximately 30 to 35 kilograms for men and 18 to 22 kilograms for women when measured with the dominant hand using proper technique. Grip strength below 26 kilograms for men or below 16 kilograms for women indicates clinically significant sarcopenia and predicts high mortality risk within 5 years. These cutoff values come from large epidemiological studies and have been validated in clinical trials. Research demonstrates that weak grip strength also indicates underlying systemic disease processes before they become clinically apparent through symptoms or routine screening tests. Cancer growing anywhere in the body, advanced heart failure causing cardiac cachexia, chronic kidney disease, liver cirrhosis, and chronic infections all cause progressive muscle wasting as the disease process consumes protein and calories faster than they can be replaced through diet. Your muscles weaken substantially before routine medical tests like tumor markers or imaging studies detect these serious conditions. Grip strength testing can identify occult disease months or years before formal diagnosis. Additionally, weak grip indicates chronic poor nutrition with inadequate protein intake and ongoing systemic inflammation. Inadequate protein intake prevents muscle protein synthesis, the process by which your body builds new muscle tissue. Chronic inflammation from any cause, whether infection, autoimmune disease, or obesity, increases muscle protein breakdown while simultaneously impairing synthesis. The net result is progressive muscle loss, reflected in declining grip strength measurements over time. Brain-muscle connections deteriorate with cerebrovascular disease and neurodegeneration affecting motor pathways. Small strokes damage upper motor neurons in the motor cortex and corticospinal tract pathways, traveling from brain through brainstem and spinal cord to muscles. Your brain cannot activate muscle fibers effectively when these neural pathways are damaged at multiple levels. Grip strength declines because the neural signaling from brain to hand muscles is impaired, not because the muscles themselves are diseased. You can measure grip strength using a hand dynamometer, an inexpensive device available for purchase online through retailers or through medical supply companies. To perform the test properly using correct technique, sit in a chair with your back supported and feet flat on the floor. Hold your elbow bent at 90 degrees with forearm resting on the arm of the chair or on a table. Adjust the dynamometer grip span so it feels comfortable in your hand. Squeeze the dynamometer as hard as possible using maximum effort for 5 seconds while the device records peak force generated. Perform this test 3 times with each hand, alternating hands between trials with 30-second rest periods to prevent fatigue from affecting results. Record the highest measurement from either hand as your grip strength score. Values significantly below the ranges mentioned above, below 26 kilograms for men or 16 kilograms for women, predict higher mortality within 5 years and warrant comprehensive medical evaluation for underlying causes including nutritional deficiencies, chronic diseases, and neurological problems. Sign number 14. Cognitive processing speed declining more than 20% over 2 years. Processing speed, operationally defined as how quickly your brain can perceive and interpret incoming sensory information, then formulate and execute an appropriate response, declines naturally with normal aging, but accelerated decline substantially beyond age expectations predicts dementia development and mortality. Research from the journal Neurology measured processing speed in adults over age 75 using standardized neuropsychological tests, including digit symbol substitution tests, trail-making tests, and computerized reaction time measures. The longitudinal study followed participants for 10 years, tracking cognitive diagnoses, including Alzheimer's disease and vascular dementia, and deaths from all causes. Results demonstrated that rapid processing speed decline, operationally defined as decline exceeding 1.5 standard deviations beyond age-adjusted norms over a 2-year period, predicted dementia diagnosis within the subsequent 5 years in over 60% of cases. Processing speed decline also predicted mortality independent of dementia diagnoses after controlling for other variables, suggesting it reflects overall brain health and systemic physiological decline beyond just cognitive impairment. Here's why processing speed matters fundamentally for cognition and survival. Processing speed underlies virtually all other cognitive functions and domains. To successfully remember new information, you must first process that information quickly enough to encode it into memory storage systems in the hippocampus and related temporal lobe structures. To solve complex problems, you must process information rapidly enough to hold it in working memory and manipulate it mentally using frontal lobe executive systems. To communicate effectively in conversations, you must process language quickly, both when comprehending other speech and when formulating your own verbal responses. When processing speed slows significantly beyond normal aging, all cognitive domains inevitably suffer secondary impairment as a consequence. The neurobiological mechanism underlying processing speed decline involves progressive white matter deterioration throughout the brain. White matter consists of billions of myelinated axons, essentially insulated nerve fibers connecting different brain regions. These white matter pathways allow rapid communication and information transfer between spatially separated brain areas performing different cognitive functions. The myelin sheath wrapping the axons acts like insulation on electrical wires, dramatically increasing the speed at which electrical signals travel along axons from one neuron to another. Vascular disease damages white matter through multiple mechanisms operating simultaneously. Small vessel disease affects the tiny arteries, arterioles, and capillaries supplying deep brain structures and white matter regions. These small vessels become diseased with walls thickened by lipohyalinosis and arteriosclerosis, and lumens progressively narrowed. Blood flow decreases below levels necessary to maintain tissue health and cellular metabolism. Over months and years of chronic hypoperfusion, this inadequate blood supply causes white matter hyperintensities, areas of damaged or dead tissue visible on MRI scans as abnormally bright spots on FLAR sequences. Additionally, complete occlusion of small vessels causes lacunar infarcts, small strokes typically less than 15 millimeters in diameter. These small infarcts accumulate over time, each one destroying a small volume of brain tissue. The more extensive the white matter damage accumulates, the slower processing speed becomes, because information must travel through damaged pathways where neural transmission is impaired. Signals travel more slowly through demyelinated axons. Some signals cannot traverse completely infarcted tissue and must find alternate routes through circuitous pathways. Processing speed testing can be performed in medical offices and research settings using standardized instruments with established norms. Common tests include the digit symbol substitution test, where you match numbers to symbols as quickly as possible following a printed key, trail making test part A, where you connect numbered circles in sequence as fast as possible, and computerized simple reaction time tests measuring how quickly you respond to visual or auditory stimuli by pressing a button. Healthy 75-year-olds typically complete the digit symbol substitution test with scores around 40 to 50 correct symbol number matches in the standard 90-second time limit. Scores below 30 indicate significantly impaired processing speed, requiring further evaluation. Declining scores over time tracked at annual visits, particularly decreases exceeding 20% within a 2-year period, strongly predict dementia development within 3 to 5 years and warrant aggressive intervention to slow cognitive decline progression through treatment of vascular risk factors, cognitive training, and physical exercise programs. Sign number 13. Blood pressure variability with day-to-day fluctuations exceeding 15 millimeters per mercury standard deviation. Blood pressure that varies widely from measurement to measurement and from day to day, with some readings very high and others very low, predicts stroke occurrence and accelerated cognitive decline more accurately than average blood pressure levels. Research from the journal Hypertension examined blood pressure variability in older adults using home blood pressure monitoring devices that automatically record and store measurements taken multiple times daily over weeks. Studies analyzed multiple variability metrics, including standard deviation of readings, coefficient of variation, adjusting for mean pressure, and average real variability, measuring successive changes. Findings demonstrated that blood pressure variability, assessed as an independent predictor separate from mean blood pressure, predicted stroke risk more accurately than average systolic blood pressure, a finding that surprised many hypertension researchers who traditionally focused only on mean pressure values. People with high blood pressure variability, operationally defined as standard deviation greater than 15 millimeters per mercury for systolic readings over 1 week of home monitoring, had 3 to 4 times higher stroke risk over the subsequent 5 years compared to those with stable blood pressure at similar average levels. The elevated risk persisted even after controlling for mean blood pressure, use of antihypertensive medications, and traditional cardiovascular risk factors. Here's the physiological mechanism explaining this strong association. Normal blood pressure regulation involves precisely coordinated responses from the heart adjusting cardiac output, blood vessels adjusting peripheral resistance through constriction and dilation, kidneys adjusting fluid volume through sodium and water retention or excretion, and autonomic nervous system coordinating all these responses. Blood pressure should vary somewhat throughout the day in predictable circadian patterns, rising with physical activity, mental stress, and sympathetic nervous system activation upon awakening, then falling during sleep and rest periods when parasympathetic tone dominates. But these physiological variations should remain within a relatively narrow range, typically not exceeding 20 millimeters mercury systolic variation across a full day. High blood pressure variability, substantially exceeding these normal ranges, indicates that multiple regulatory mechanisms are failing simultaneously. Blood vessels throughout the body, including delicate cerebral vessels, have lost normal elasticity and compliance. They cannot constrict and dilate smoothly and appropriately in response to changing physiological demands and conditions. The autonomic nervous system, which normally coordinates cardiovascular responses through balanced sympathetic and parasympathetic branches, is dysfunctional due to age-related changes, diabetes damaging autonomic nerves, and neurodegenerative diseases. Research demonstrates that people with high blood pressure variability have dramatically elevated rates of cognitive decline and dementia. Each 10 millimeters mercury increase in blood pressure variability, measured as standard deviation of home readings, correlates with approximately 15% increased dementia risk over 10 years. This association remains statistically significant even after controlling for average blood pressure levels, indicating variability has independent pathological effects on brain tissue. The mechanism linking blood pressure variability to progressive brain damage involves repeated injury cycles to the small blood vessels perfusing brain tissue. When blood pressure swings to high levels during peaks, the elevated pressure directly damages delicate vessel walls in the brain's microcirculation through mechanical stress. Endothelial cells lining the inner surface of vessels become injured and dysfunctional. The blood-brain barrier becomes abnormally leaky, allowing proteins and inflammatory cells to enter brain tissue. Inflammatory processes activate, causing further damage. When blood pressure subsequently drops to very low levels during troughs, brain tissue becomes ischemic from inadequate perfusion and oxygen delivery. Neurons are exquisitely sensitive to hypoxia and begin suffering metabolic stress within minutes of inadequate oxygen supply. This repeated cycle of hypertensive mechanical injury, followed by hypoperfusion and ischemia, accumulates over months and years, causing progressive white matter damage, small vessel disease with lipohyalinosis and arteriolosclerosis, multiple small lacunar infarcts, and eventually larger symptomatic strokes and progressive dementia. If you monitor blood pressure at home using an automatic oscillometric monitor, keep a detailed written log recording all measurements with dates, times, and any symptoms. After accumulating at least 20 to 30 measurements over 2 to 4 weeks, calculate basic descriptive statistics, including mean, standard deviation, and range. If you see extreme variability, with some readings at 180 over 100 millimeters mercury and others at 100 over 60 millimeters mercury within the same week, this indicates dangerous vascular instability that requires urgent medical evaluation and treatment adjustments to stabilize pressure and prevent stroke. Sign number 12. Inability to perform dual tasks simultaneously without significant performance decline. Dual task performance, operationally defined as the ability to perform two different tasks concurrently without significant deterioration in performance of either task, requires substantial cognitive resources and intact distributed brain networks. Declining dual task ability predicts dementia development and mortality with impressive accuracy. Research from JAMA Neurology tested dual task performance in community-dwelling older adults using standardized protocols. Participants first walked a specified distance of 20 feet at their normal, comfortable pace on a flat surface, while researchers measured walking speed with stopwatches. Then participants walked the same distance while simultaneously performing cognitive tasks, such as counting backwards from 100 by threes, naming as many animals as possible, or reciting alternate letters of the alphabet. Studies measured dual task cost, calculated as the percentage decrease in walking speed when simultaneously performing the cognitive task compared to walking alone without any cognitive load. Results showed that dual task cost exceeding 20%, meaning walking speed decreased by more than 20% when adding the concurrent cognitive task, predicted dementia diagnosis within 18 to 24 months with over 80% sensitivity, the ability to detect people who will develop dementia, and over 70% specificity, the ability to correctly identify people who will not develop dementia. Here's why dual task performance matters so much for brain health assessment. Single isolated tasks use relatively localized brain regions. Walking primarily uses motor cortex, basal ganglia for movement initiation and control, and cerebellum for coordination and balance. Verbal fluency tasks like naming animals primarily use language areas in the left hemisphere, including Broca's and Wernicke's areas. But performing both tasks simultaneously requires coordination across multiple distributed brain networks spanning different lobes and hemispheres. Frontal lobes, particularly dorsolateral prefrontal cortex, must allocate limited attentional resources between two competing tasks. Motor systems must maintain gait stability, rhythm, and safety, while cognitive resources are divided between walking and the verbal task. This requires intact structural white matter connections and functional connectivity between widely separated brain regions, adequate processing speed to handle information streams from both tasks, and sufficient cognitive reserve to buffer against age-related and disease-related brain changes. When you cannot walk and talk simultaneously, demonstrated by stopping in your tracks whenever someone asks a question requiring thought, or by walking speed decreasing more than 20%, this indicates severe brain network dysfunction affecting multiple cognitive domains in brain regions simultaneously. The impairment reflects not just isolated damage to a single brain area, but rather widespread disruption of the neural networks that integrate information and coordinate complex behaviors requiring attention division. The neurobiological mechanism underlying dual task impairment involves widespread brain damage affecting structural and functional connectivity. Dual task performance requires intact frontal parietal attention networks controlling top-down attention allocation, preserved white matter connections linking frontal executive regions to posterior motor and sensory areas, and functioning basal ganglia circuits coordinating automatic motor sequences. When cerebral vascular disease causes extensive white matter damage throughout frontal, parietal, and temporal lobes, or when neurodegeneration affects multiple brain regions simultaneously, these distributed networks fail. Information cannot flow efficiently between brain areas. Coordination between different processing streams breaks down. Brain imaging using MRI demonstrates that people with poor dual task performance exceeding 20% cost have extensive white matter hyperintensities distributed throughout frontal, parietal, and temporal lobes bilaterally, significantly reduced gray matter volumes in frontal and parietal cortex reflecting neuronal loss and atrophy, evidence of multiple small cortical and subcortical infarcts, and reduced functional connectivity between brain regions on resting state functional MRI sequences, measuring spontaneous neural activity correlations. You can test dual task ability at home using a simple protocol requiring only a hallway, tape, and stopwatch. First, mark a 20-foot distance on a flat surface and walk it at your normal pace. Have someone time how long this takes. Rest for 2 minutes, then walk the same 20 feet while counting backwards from 100 by threes out loud. Again, have someone time this. Calculate the percentage difference between the two times. If the second time is more than 20% slower than the first time, this indicates significant brain network dysfunction, predicting dementia development within 1 to 2 years and warrants urgent neurological evaluation. Sign number 11. Unintentional weight loss exceeding 5% of body weight within 6 months. Losing weight without intentionally trying through deliberate diet changes or increased exercise after age 75 predicts mortality within 1 to 2 years. Research from the American Journal of Clinical Nutrition examined unintentional weight loss in adults over age 75 using longitudinal data from multiple large cohort studies. Studies defined clinically significant unintentional weight loss as losing 5% or more of total body weight over 6 months without deliberate efforts to lose weight through dieting or exercise programs. Results demonstrated that losing more than 5% of body weight unintentionally doubled all-cause mortality risk within the subsequent 2 years. Losing more than 10% of body weight tripled mortality risk. The association remains strong even after controlling for baseline weight and body mass index, presence of chronic diseases, smoking status, and demographic factors, indicating weight loss itself carries independent prognostic information about remaining lifespan. Here's what unintentional weight loss indicates about underlying disease. Unintentional weight loss in older adults signals serious underlying disease processes in the vast majority of cases. Occult cancer growing anywhere in the body consumes substantial calories and releases cytokines, tumor necrosis factor, and other substances that suppress appetite through effects on hypothalamic feeding centers. Advanced heart failure causes cardiac cachexia, a wasting syndrome resulting from neurohormonal activation, chronic systemic inflammation, and inadequate nutrient absorption due to gut edema from venous congestion. Progressive chronic kidney disease leads to uremia that profoundly suppresses appetite while simultaneously increasing metabolic demands. Advancing dementia causes progressive weight loss through multiple mechanisms, including forgetting to eat meals, difficulty with eating mechanics like using utensils, reduced appetite from brain changes affecting hypothalamic feeding regulation, and increased energy expenditure from agitation or wandering behaviors common in moderate to severe dementia. Major depression deepens over time, eliminating appetite and motivation to prepare and eat meals through effects on hypothalamic pituitary adrenal axis and neurotransmitter systems. Any of these serious conditions substantially shortens lifespan. Additionally, weight loss creates a self-perpetuating vicious cycle, accelerating overall decline. As you lose weight, you disproportionately lose muscle mass rather than just adipose fat tissue, because muscle is metabolically expensive to maintain and your body sacrifices it first during caloric deficit. Muscle loss reduces strength, impairs physical function and activities of daily living, and decreases basal metabolic rate. You become progressively frailer and more vulnerable to infections from impaired immune function, falls leading to fractures, pressure ulcers from immobility, and complications from any acute illness. Your immune system weakens as protein and micronutrient stores become progressively depleted. Recovery from any illness becomes increasingly unlikely as nutritional status deteriorates. Brain imaging studies using serial MRI scans demonstrate that unintentional weight loss strongly correlates with accelerated brain atrophy. Research shows that people losing weight have faster rates of total brain volume loss measured by automated volumetric analysis, and specifically accelerated atrophy in hippocampus, essential for memory formation, and frontal regions controlling executive function and behavior. The brain is literally shrinking as the body progressively wastes away. If you're experiencing unintentional progressive weight loss, this demands urgent, comprehensive medical evaluation. Potentially treatable, reversible causes must be identified and aggressively addressed. These potentially include depression responding to antidepressant medications and psychotherapy, medication side effects causing nausea or altered taste that can be addressed by switching drugs, dental problems making chewing painful that can be fixed with dental care, and malabsorption from conditions like celiac disease or pancreatic insufficiency that can be treated. But progressive unintentional weight loss, despite appropriate interventions, indicates serious irreversible disease with very limited remaining time. Sign number 10. Sleeping more than 9 hours per night regularly on most nights of the week. Excessive sleep duration after age 75, operationally defined as sleeping more than 9 hours per night on average across most nights of the week, predicts dementia development, stroke occurrence, and all-cause mortality. Research from the journal Neurology examined sleep duration and health outcomes in adults over age 75 followed longitudinally for 10 years. Studies measured self-reported sleep duration using validated questionnaires and objectively measured sleep using wrist actigraphy devices worn continuously for 1 to 2 weeks, recording movement patterns. Results demonstrated that sleeping more than 9 hours per night on average associated with double the dementia risk over 10 years compared to sleeping 7 to 8 hours, considered the optimal range for this age group. Each additional hour of sleep beyond 8 hours per night increased stroke risk by approximately 20%. Sleeping more than 10 hours per night on average predicted 3 times higher mortality risk from all causes. Here's the physiological mechanism underlying these associations. Sleep need typically decreases slightly with normal aging as sleep architecture changes with age. Most healthy older adults need 7 to 8 hours of sleep nightly for optimal cognitive and physical function. Consistently sleeping substantially more than 9 hours on most nights suggests several concerning possibilities about underlying health status that predict poor outcomes. Your brain may be significantly damaged and requires more sleep than normal to attempt repair processes and clearance of toxic metabolic byproducts, including beta amyloid that accumulate during waking hours. Your body may be fighting chronic infection, ongoing inflammatory processes, or malignancy requiring extra sleep to support immune function and tissue repair. You may have obstructive sleep apnea, making sleep quality so poor that you need excessive total sleep duration to accumulate adequate restorative slow wave and REM sleep. You may be experiencing clinical depression, manifesting as hypersomnia and using sleep to escape negative emotions and anhedonia. Additionally, excessive sleep duration indicates dysfunction in brain circuits regulating sleep-wake cycles. The suprachiasmatic nucleus in the hypothalamus serves as the master circadian pacemaker, synchronizing sleep-wake timing. Brainstem nuclei, including the reticular activating system, control sleep-wake transitions and arousal. When these systems are damaged by neurodegeneration or vascular disease, normal sleep-wake regulation fails and sleep becomes fragmented and excessively prolonged. Brain imaging demonstrates that people who habitually sleep more than 9 hours per night have more extensive white matter damage visible on MRI scans as confluent hyperintensities and more severe generalized brain atrophy measured by automated volumetric analysis compared to normal sleepers, even after statistically controlling for age and vascular risk factors. The damaged brain apparently requires more downtime, attempting to maintain minimal function. Furthermore, lying in bed for extended periods substantially reduces total daily physical activity and increases sedentary time. Sedentary behavior independently accelerates both cognitive and physical decline through multiple mechanisms, including reduced cardiovascular fitness, impaired glucose metabolism, increased inflammation, and reduced brain-derived neurotrophic factor. Prolonged recumbency causes blood to pool in dependent leg veins, increasing risk of deep vein thrombosis, potentially leading to pulmonary embolism. If you're consistently sleeping more than 9 hours per night while still feeling tired and unrefreshed upon awakening, this warrants comprehensive medical evaluation. Polysomnography sleep studies can diagnose obstructive sleep apnea and other primary sleep disorders. Brain imaging can detect strokes, mass lesions, or neurodegenerative changes causing excessive sleep need. Screening for depression, anemia, thyroid disorders, and other medical conditions affecting energy and sleep is essential. Sign number 9, developing new onset urinary incontinence or experiencing sudden worsening of existing incontinence. Bladder control loss after age 75, particularly when developing suddenly rather than gradually over many years, predicts dementia development and shortens survival. Research published in the journal Stroke examined urinary incontinence in stroke survivors. Studies found that incontinence developing within 1 year of an acute stroke predicted rapid cognitive decline and dramatically elevated mortality. People who became incontinent following stroke had twice the death rate within 2 years compared to stroke survivors who maintained bladder control despite similar stroke severity and location. Here's why incontinence predicts such poor outcomes. Maintaining voluntary bladder control requires intact complex neural pathways connecting frontal cortex, brainstem nuclei, and sacral spinal cord segments. Frontal lobes, particularly the medial frontal cortex and anterior cingulate, provide voluntary inhibitory control, allowing you to consciously suppress the urge to urinate until reaching an appropriate socially acceptable location. Pontine micturition center in the brainstem coordinates the bladder contraction reflex and sphincter relaxation. Sacral spinal cord integrates signals and directly controls detrusor muscle and pelvic floor muscles. When these distributed neural pathways are damaged by strokes affecting frontal regions or deep white matter disease, disrupting long-distance connections, or neurodegeneration affecting multiple brain levels, bladder control inevitably fails. The mechanism involves loss of descending inhibitory control from frontal cortex to brainstem and spinal cord. Without cortical inhibition, primitive brainstem and spinal reflexes become disinhibited and hyperactive. The bladder contracts reflexively at small fill volumes before you consciously perceive fullness or urge to void. The presence of neurogenic urinary incontinence indicates extensive brain damage affecting frontal regions controlling executive function and voluntary behavior, deep brain structures coordinating autonomic reflexes, and white matter pathways connecting these widely separated areas. This widespread damage pattern indicates advanced disease stage with extensive brain involvement. Additionally, research shows that urinary incontinence in patients with established dementia predicts especially rapid disease progression to severe stages. Studies demonstrate that once incontinence develops in Alzheimer's disease patients, average survival duration from that point is less than 2 years. Incontinence indicates the disease has damaged frontal cortex severely and extensively and has progressed to moderate or severe stages. Brain imaging reveals that incontinent patients have severe generalized brain atrophy with dramatically reduced total brain volumes compared to age-matched controls, extensive white matter hyperintensities affecting all lobes bilaterally, indicating widespread small vessel disease, and multiple focal areas of infarcted tissue from acute and chronic strokes visible as focal signal abnormalities on T2 and FLAIR sequences. If you develop new-onset urinary incontinence or experience sudden worsening of previously mild incontinence over weeks to months, comprehensive medical evaluation is essential. Potentially treatable causes must be systematically ruled out through appropriate testing. These include urinary tract infections causing temporary incontinence that resolves completely with appropriate antibiotic treatment, medications with anticholinergic or sedative effects impairing bladder control that can be adjusted or discontinued, benign prostatic hyperplasia in men causing overflow incontinence treatable with alpha blocker medications or surgical procedures, and pelvic floor weakness in women responding to pelvic floor physical therapy or surgical repair. But if comprehensive evaluation reveals that the cause is neurological damage from strokes or dementia, this indicates serious underlying brain pathology with limited remaining lifespan. Sign number 8, experiencing 2 or more falls within 1 year. Frequent falls after age 75 dramatically predict mortality within 1 to 2 years. Research from the Journal of the American Geriatric Society examined fall frequency and outcomes in community-dwelling older adults. Studies used detailed fall calendars where participants prospectively recorded all falls, including date, location, mechanism, and injuries sustained. Results demonstrated that people over age 75 experiencing 2 or more falls within 1 year had 5 times higher mortality risk in the subsequent year compared to non-fallers who experienced no falls. Each additional fall beyond 2 increased risk progressively in a dose-dependent manner. Here's the mechanism linking falls to such dramatically poor outcomes. Falls result from catastrophic failure of highly integrated systems maintaining upright balance and postural stability. Balance requires rapid processing of sensory input from 3 distinct sources: the vestibular system in inner ears detecting head position and angular acceleration, visual system providing information about environment and body position in space, and proprioceptors in muscles and joints throughout the body signaling limb position and movement. Your brain must integrate these diverse sensory inputs within milliseconds and coordinate rapid corrective muscle responses throughout the body to maintain upright posture when balance is threatened by perturbations. When you fall, this entire highly integrated system has catastrophically failed at multiple levels. Research demonstrates that frequent fallers have substantially reduced brain volumes in cerebellum, controlling motor coordination and postural balance, and in frontal regions planning movements and coordinating complex motor sequences. MRI scans reveal extensive white matter damage, disrupting connections between sensory areas receiving vestibular, visual, and proprioceptive input, and motor areas executing corrective responses. Evidence of multiple small strokes appears throughout the brain, particularly affecting basal ganglia involved in motor control, and thalamus relaying sensory information. Additionally, falls cause serious injuries that directly shorten lifespan through multiple mechanisms. Hip fractures occur in approximately 30% of older adults who fall, with higher rates in those with osteoporosis. After sustaining a hip fracture, 1-year mortality ranges from 20 to 30% across multiple studies examining outcomes. Many survivors never regain pre-fracture mobility and independence, requiring nursing home placement. Head trauma from falls causes subdural hematomas in anticoagulated patients and traumatic brain injury worsening dementia. Falls also indicate dramatically increased stroke risk. The same cerebrovascular disease causing balance problems in falls simultaneously affects other brain regions controlling cognition and vital functions. Research shows that people experiencing frequent falls have 3 to 4 times higher stroke risk within the subsequent year. The falls are essentially a symptom of widespread vascular brain disease that will soon cause a major disabling stroke. If you're experiencing frequent falls, defined as 2 or more within 1 year, comprehensive evaluation must identify and address all contributing factors. Potentially modifiable contributors include vitamin D deficiency causing muscle weakness and balance impairment that corrects with high-dose supplementation, medications affecting balance, including sedatives, blood pressure medications causing orthostatic hypotension, and drugs with anticholinergic effects that can be discontinued or switched to safer alternatives. Vision problems, including cataracts or uncorrected refractive errors that can be treated, and environmental hazards in the home, like poor lighting, clutter, loose rugs, or slippery bathroom floors that can be modified. But recurrent falls, despite comprehensive interventions addressing all modifiable factors, indicate severe, irreversible neurological dysfunction with very poor prognosis. At this point, the focus shifts from fall prevention to harm reduction through protective equipment and environment modification. Sign number 7, speech becoming noticeably slower with frequent pauses and word-finding difficulties. Declining speech production rate and fluency predict dementia progression and mortality with remarkable precision. Research from the journal Brain examines speech patterns using sophisticated computer analysis and natural language processing algorithms. Studies recorded spontaneous speech during semi-structured interviews and measured multiple parameters, including speaking rate, measured in words per minute, pause duration and frequency between words and sentences, word-finding delays manifesting as unfilled pauses, and grammatical complexity measured by words per clause. Results demonstrated that speaking rate declining more than 15% over 1 year predicted progression from mild cognitive impairment to severe dementia within 2 years in the majority of cases. Additionally, speech slowing predicted mortality independent of dementia diagnosis after statistically controlling for cognitive status, suggesting it reflects overall brain health deterioration and systemic physiological decline beyond just cognitive impairment. Here's why speech production rate matters fundamentally for brain health assessment and longevity prediction. Speech production requires extraordinarily rapid coordination of language areas in the left hemisphere, motor cortex controlling muscles of mouth, tongue, larynx, and respiratory system, and brainstem nuclei controlling breathing patterns and rhythm. You must retrieve appropriate words from your mental lexicon stored in temporal lobe regions, plan grammatical structure and word order using frontal language areas, and execute precise muscle movements coordinated by motor cortex, all within milliseconds for each syllable produced during fluent speech. When speech slows dramatically with abnormally long pauses exceeding 2 seconds as you search for common everyday words and struggle to form complete grammatical sentences, this indicates progressive breakdown of language network connectivity and function. The impairment reflects not just isolated damage to a single language area, but rather widespread disruption of the distributed neural networks supporting language production spanning frontal, temporal, and parietal regions. The neurobiological mechanism underlying progressive speech slowing involves accumulating damage to language regions and their interconnecting pathways. Small strokes affecting left hemisphere language areas, including Broca's area in inferior frontal gyrus and Wernicke's area in superior temporal gyrus, progressive neurodegeneration destroying neurons in these critical language regions, and white matter deterioration damaging the arcuate fasciculus and other major pathways connecting language areas all contribute synergistically. Your brain progressively loses the ability to access vocabulary rapidly and coordinate the complex motor sequences required for fluent speech production. Brain imaging using MRI demonstrates that people with markedly slowed speech have extensive left hemisphere damage, including reduced gray matter volumes in Broca's area and Wernicke's area measured by automated volumetric analysis, white matter hyperintensities throughout the left hemisphere affecting language pathways, and progressive generalized brain atrophy measured by increasing ventricular size and widening cortical sulci. Sign number 6, developing recurrent complex visual hallucinations. Visual hallucinations occurring after age 75, particularly complex formed hallucinations of people, animals, or objects, indicate either Lewy body dementia or advanced vascular dementia with extensive posterior brain damage. Both conditions predict dramatically shortened survival compared to other dementia types. Research from the journal Neurology examined hallucinations in dementia patients using standardized structured interviews and validated caregiver questionnaires. Studies found that recurrent complex visual hallucinations predicted rapid disease progression through dementia stages and substantially shortened survival duration. People with dementia experiencing recurrent visual hallucinations survived an average of only 2.5 years from hallucination onset, compared to 4.5 years for dementia patients without hallucinations. Here's the neurobiological mechanism. Visual hallucinations result from severe dysfunction in visual processing areas of occipital lobes and visual association areas in temporal and parietal cortex. Your brain generates detailed visual percepts, essentially seeing things without corresponding external visual stimuli actually entering through your eyes and traveling to brain. This occurs when the normal balance between bottom-up sensory input from the eyes traveling to visual cortex and top-down cognitive processing in higher brain areas breaks down due to extensive neuronal damage. In Lewy body dementia, abnormal protein deposits called Lewy bodies, consisting of aggregated alpha-synuclein protein, accumulate extensively in visual cortex in the occipital lobes. These pathological protein aggregates kill neurons progressively over time. As visual processing regions degenerate extensively, the damaged brain generates false visual perceptions. Patients see detailed, complex hallucinations, including people who aren't actually present in the room, small animals like cats or children, or inanimate objects. The hallucinations are typically recurrent, stereotyped in content, and occur predominantly in evening hours when environmental lighting is reduced. In vascular dementia, multiple strokes affecting posterior circulation territories damage visual pathways bilaterally throughout both hemispheres. The damaged regions produce aberrant spontaneous neural activity that the brain misinterprets as actual visual input, generating vivid hallucinations indistinguishable from reality to the patient. Brain imaging using MRI reveals severe atrophy specifically in occipital and posterior parietal regions in patients experiencing visual hallucinations. Reduced metabolism in these regions appears on positron emission tomography scans using fluorodeoxyglucose as tracer. The extent of posterior brain damage and hypometabolism correlates with hallucination frequency and complexity. If you or a loved one experiences recurrent visual hallucinations, seeing things that others don't see and that aren't actually present in the environment, this indicates extensive brain damage throughout visual networks and predicts very limited remaining survival time, typically less than 3 years from hallucination onset. Treatment with medications, including cholinesterase inhibitors, may reduce hallucination frequency and severity, but cannot reverse underlying neurodegeneration. Focus shifts to safety and quality of life as disease progresses rapidly. Sign number 5, complete loss of sense of smell, termed anosmia. Complete loss of smell predicts neurodegenerative disease and mortality years before other obvious symptoms appear. Research from Annals of Neurology examined smell function using standardized smell identification tests in community-dwelling older adults. The University of Pennsylvania Smell Identification Test, a validated 40-item scratch and sniff test, was administered to thousands of participants aged 70 to 90 who were then followed prospectively for up to 15 years, tracking dementia diagnoses and deaths. Studies found that complete anosmia, operationally defined as inability to identify any of the 40 common odors correctly beyond chance-level guessing, predicted death within 5 years with remarkable accuracy. People over age 75 with complete anosmia had nearly 4 times higher mortality risk compared to those with normal smell function. Smell loss predicted death more accurately than having diagnosed cancer, heart failure, or lung disease at baseline. Here's the mechanism. Olfactory pathways involve specialized olfactory receptor neurons located in the nasal epithelium high in the nasal cavity, sending unmyelinated axons through the cribriform plate of the ethmoid bone to olfactory bulbs located at the base of the frontal lobes. From olfactory bulbs, neural signals travel through olfactory tracts to primary olfactory cortex in the temporal lobes and limbic structures, including amygdala and entorhinal cortex in the medial temporal lobe. These olfactory pathways are among the very first brain regions affected by neurodegenerative diseases, including Parkinson's disease and Alzheimer's disease. In Parkinson's disease, abnormal alpha-synuclein protein accumulation begins in olfactory bulbs and brainstem nuclei years before motor symptoms of tremor and rigidity appear, then spreads progressively throughout the brain following predictable anatomical pathways described by Braak staging. By the time smell is completely lost, the neurodegenerative process is already well advanced throughout multiple brain regions beyond just olfactory areas. In Alzheimer's disease, tau protein tangles and amyloid plaques appear very early in entorhinal cortex, a key olfactory processing region. Smell loss indicates these pathological proteins have already extensively damaged the brain's olfactory networks. Additionally, smell loss strongly predicted dementia diagnosis. Research showed that complete anosmia predicted dementia development within 5 years in over 50% of cases, and Parkinson's disease diagnosis in approximately 20% of cases. The smell loss occurred on average 5 to 10 years before cognitive or motor symptoms became clinically apparent to patients or families. Brain imaging studies demonstrate that people with complete anosmia have significantly reduced volumes in olfactory bulbs visible on high-resolution MRI scans, progressive atrophy in entorhinal cortex and hippocampus in the medial temporal lobes, and evidence of widespread neurodegenerative changes throughout the brain, including reduced cortical thickness and increased ventricular volume. If you've lost your sense of smell completely, unable to detect even strong odors like coffee, peppermint, or smoke without obvious reversible cause like head trauma, chronic rhinosinusitis, or recent viral upper respiratory infection, this indicates neurodegenerative disease is already progressing and damaging your brain. While no current treatments can reverse olfactory loss or stop underlying neurodegeneration, early diagnosis allows for advanced care planning, clinical trial participation, and symptomatic treatment as other symptoms develop. Sign number 4, multiple warning signs occurring simultaneously in combination. The single most powerful predictor of remaining lifespan is not any individual sign, but rather experiencing multiple warning signs from this list simultaneously. Research consistently demonstrates across multiple studies that combinations of risk factors predict outcomes far more accurately than isolated individual findings. This reflects the reality that biological aging is a multi-system process, not isolated organ failure. If you have slow walking speed below 0.8 meters per second, weak grip strength below threshold values, declining cognitive processing speed exceeding 20% over 2 years, elevated blood glucose consistently above 100 milligrams per deciliter, excessive sedentary time sitting more than 9 hours daily, and social isolation with minimal social contact, all occurring together simultaneously, this indicates advanced biological aging affecting multiple organ systems with substantially shortened remaining lifespan measured in years, not decades. The mechanism involves accelerated aging across cardiovascular, neurological, metabolic, and musculoskeletal systems simultaneously. Chronic inflammation damages tissues throughout the body. Oxidative stress accumulates, damaging cellular components. Telomeres shorten, limiting cell division capacity. These fundamental aging processes affect all organs simultaneously, causing multi-system decline. Conversely, if you have none of these warning signs despite being 75 or older, your biological age is substantially younger than your chronological age, predicting longer survival and extended health span. This reflects successful aging with well-preserved physiological function across multiple systems. The key is comprehensive assessment, evaluating all major organ systems, and aggressive evidence-based treatment of all modifiable risk factors to extend both lifespan and health span. Don't focus on treating just one problem while ignoring others. The integrated approach addressing cardiovascular health, brain health, metabolic health, physical function, and social engagement simultaneously produces the best outcomes. Sign number 3. Social isolation with fewer than one meaningful social contact per week. Social isolation and loneliness after age 75 predict dementia development and all-cause mortality. Research from PLOS Medicine examined social contact frequency and health outcomes in older adults. Studies found that having fewer than one meaningful social contact per week, operationally defined as in-person visit, phone call, or video chat lasting at least 15 minutes, increased mortality risk by 30% compared to having daily social contact with family or friends. Social isolation also doubled dementia risk over 10 years. The mechanism involves multiple pathways. Social interaction stimulates multiple brain regions simultaneously. Conversations require language processing in left hemisphere, working memory in frontal regions, attention and executive function, and emotional regulation in limbic structures and prefrontal cortex. Social activities provide cognitive stimulation that builds cognitive reserve, the brain's ability to maintain function despite accumulating pathology. Isolation deprives the brain of this essential stimulation. Neurons aren't activated regularly. Synaptic connections weaken through lack of use. Brain atrophy accelerates, particularly in frontal and temporal regions. Additionally, isolation increases depression risk through reduced social support and increased loneliness. Depression independently contributes to cognitive decline and mortality through multiple mechanisms, including increased inflammation, HPA axis dysregulation, and reduced health behaviors. If you have minimal social contact with isolation, actively seek engagement through community senior centers, religious organizations, volunteer activities, phone calls to family and friends, or video chat technology. Even limited social interaction provides substantial brain health benefits compared to complete isolation. Sign number 2, sitting time exceeding 9 hours per day on most days. Excessive sedentary time after age 75 predicts mortality independent of exercise and physical activity. Research from Annals of Internal Medicine examined sitting time using wearable activity monitors and health outcomes. Studies found that sitting more than 9 hours daily on average associated with significantly increased death risk. Each additional hour of sitting beyond 9 hours increased mortality risk by 10%, even after controlling for moderate to vigorous physical activity duration. Here's why sitting matters. Prolonged, uninterrupted sitting reduces metabolic rate, impairs glucose metabolism, promoting insulin resistance, and promotes chronic systemic inflammation. Blood flow slows in leg veins, increasing risk of thrombosis. Muscles remain inactive, accelerating sarcopenia even in people who exercise regularly. Sedentary behavior also impairs brain health. Brain imaging shows that people who sit more have thinner medial temporal lobes, essential for memory formation. The thinning occurs independent of physical activity levels, suggesting sitting itself damages the brain beyond just lack of exercise. If you sit more than 9 hours daily, break up sitting time with standing or walking breaks every 30 minutes. Even brief 2-minute standing breaks reduce the metabolic harm of prolonged sitting. Use a timer or smartphone app to remind you to stand and move regularly. Sign number 1. Fasting blood glucose consistently above 100 milligrams per deciliter, indicating prediabetes. Elevated fasting blood glucose after age 75, even below diagnostic thresholds for diabetes, predicts dementia development and shortened lifespan. Research from Diabetologia examined glucose levels and brain health. Studies found that average fasting glucose above 110 milligrams per deciliter associated with accelerated brain atrophy measured on serial MRI scans. Each 10 milligrams per deciliter increase in average glucose correlated with approximately 1% faster brain volume loss per year. Here's the mechanism. Elevated glucose damages blood vessels through glycation. Glucose molecules attach abnormally to proteins, forming advanced glycation end products. These accumulate in vessel walls, causing dysfunction. Over years, cerebral small vessel disease develops. White matter damage accumulates extensively. Additionally, insulin resistance impairs brain glucose metabolism. The brain can't use glucose efficiently for energy production. This metabolic dysfunction contributes to neurodegeneration. Research shows prediabetes, glucose 100 to 125 milligrams per deciliter fasting, increases dementia risk 20%. Diabetes increases risk 50 to 100%. If fasting glucose is consistently above 100 milligrams per deciliter or hemoglobin A1C above 5.7%, this predicts cognitive decline and should be treated aggressively through diet, exercise, weight loss, and potentially metformin medication. Which of these signs surprised you most? Have you noticed any warning signs in yourself or loved ones? Share your experiences in the comments below. If this information helped you understand your body's signals about biological aging and remaining lifespan, please like this video and subscribe to our channel for more evidence-based health content that could extend your health span and help you live longer with better quality of life.